Assalamu alaikum and welcome to this week's Journal Club. Today I'll be presenting a paper by Karrar, published in May of 2025, titled Clinical Validation of a Proposed Diagnostic Classification for Pulpitis. So the current pulpitis classifications by the AAE are binary and may not reflect the spectrum of pulpal inflammation. Given advances in vital pulp therapy, there is a need for a more granular diagnostic framework. And Walters et al. In 2017 proposed a four-category system, which was initial, mild, moderate, and severe, with corresponding treatment strategies. However, it did lack clinical validation. So the study design for this paper was a prospective diagnostic accuracy study, which was conducted to assess the reliability and the clinical validity of the Walters classification for pulpitis. It involved 92 patients with deep or extremely deep caries and responsive pulps, and they were followed for 12 months after receiving treatments based on the classification. The aims were as follows. They wanted to evaluate the inter-rater reliability of the Walters classification, to assess the face validity, to determine construct validity via unsupervised cluster analysis, and to assess predictive validity based on 12-month treatment outcomes. For the diagnosis, they classified it into four categories as per the Walters classification and also per the AAE classification, which was reversible and irreversible. For the treatments, the initial and mild had selective caries removal. For moderate classification, they did partial pulpotomy, and for severe, they had full pulpotomy or pulpectomy. For assessments, they used the inter-rater agreement, face validity, construct validity, and predictive validity. For the results, they had the reliability by Walters classification, which showed fair inter-rater agreement of 0.05, and the AAE classification had substantial agreement of 0.88. The construct validity was best supported by a three-category model, which was mild, moderate, severe, and the diagnostic accuracy for the mild was 100% sensitivity and 88% specificity. For the moderate, it was 83% sensitivity and 85% specificity, and for the severe, it was 100% sensitivity and 85% specificity. There was no significant difference in the 12-month treatment outcome across all categories. And for the limitation of the study, the classification was based on subjective signs and symptoms. It was also on a lack of histological validation because they treated the outcome, which was used as a proxy. The follow-up was limited to 12 months. Moderate pulpitis group had less diagnostic accuracy, and some were misclassified as severe. So in conclusion, the Walters classification with modification into three categories is a clinically valid framework for diagnosing and managing pulpitis. While less reproducible than the AAE classification, it enables the conservative treatments that preserve pulp vitality. Furthermore, refinement and long-term multi-center validations are recommended. Thank you very much.